So I'm going to do a little bit that we didn't get to do yesterday, which is me walking you through the tool here, and then right after that, head into you yourselves doing an exercise on the tool. So hopefully in maybe half an hour we can have printed out the Word document I sent earlier today. Awesome. Yeah. And then there's some projection files that I don't know if you have access to your emails, you can download or otherwise pass around with a USB key. So the OneHealth tool looks like this when you first open it up. Actually now the OneHealth tool is actually just one out of several tools within what's called the Spectrum platform, or Spectrum software. And the OneHealth tool when you open it up will look like this. So I was talking a little bit yesterday about the different components, but the first thing you always need to do is start a new file for your context or country, or open one that already exists. If we were to have started a new file, that at least is sort of relatively intuitive. You come up with this first program manager, and there you can choose the minimum or like the real basic parts of what you're going to do, what years you're going to look at. If you're projecting 3 years into the future, 5 years into the future, 1 year into the future, however, up until, what's the maximum, 100 years into the future, yeah. And then which components do you actually want to analyze? Sometimes you may feel that there's so much in the tool that maybe requires so much additional information that it doesn't help that much to also include everything. And so you can deselect and only include some of the things. Right, and the first thing is the name. And then of course you at the bottom select the country, because then you have the tool already pre-filled with a bunch of pre-existing country-specific data from the different modules. So if you had wanted to work on Russia, the data exists everywhere except for the specific household survey data within the live save tool. So that's another thing that the OneHealth tool already has a bunch of tools within it, including things like the live save tool that maybe you're already familiar with. Jeremy.
Could I just suggest as a means of proceeding that if any of you around the table lose the train, lose the thread, you're having difficulty following, put your hand up. This is an interactive session. We want you to get back on the page with us. So don't be shy. We will, sort of live real-time debugging. So
yeah, we have problems.
So I would say in this initial session, you can follow along sort of on your computer if you want to, but maybe the exercise will actually be almost the same things that I do, but following an exercise, following some steps. But yes, you can do pretty much what I have in front of me if you have it in front of you. So
yeah, I was just noticing that quite a number of us were trying to follow along.
Okay.
So maybe we can just make that.
Yeah. The only thing is that I'm going to run through a projection that's already made with data already in it. That makes it a bit more difficult to follow.
Okay.
In that sense, but at least this part where you first set up the projection definitely can be easy to follow along. So where did I lose you up until now?
We found already.
You found it? Okay. Now, the default data comes separate from when you first install the computer. There is, in this same page where you download the application, there's a little add-on that it has all of the country's data to download together. If you don't do this, every time you start a new projection with a country you've never used before, it doesn't say error, the data isn't there. It just asks you, you don't have the information, do you want to download it? And then it itself automatically connects with the developer's webpage and downloads the country-specific files, as you see happening right now. Now, there may be some repeated bits of me just standing here looking at the tool because it being quite heavy, so it takes some time to process. This is the short example. So sometimes you may think that it crashes. I like to sort of switch back between different things and working at the same time, and it seems like something is crashing. It's just you have to be a bit more patient when you use it. Okay. So now that we have picked the country, now that we have the data loaded on the computer, then we can click next to actually create the projection and start using the tool in Honest. Then you get a first prompt that you can only choose once. Once you select which way you're going to look at it, then you can, it's very difficult to switch back. And this is looking back to what I looked at yesterday in the 3 columns, how you want to look at the problems or the system. If you want to be focusing on different programs, be it NCDs or malaria or HIV or whatever, or if you want to be focusing on the specific level of delivery, the facilities, if you want to look at by hospital or by health center level or like that, you can choose how the tool is set itself up. Once you make this choice, it sort of fixes it, and it reminds you several times about this. But we're looking at, we're really focusing on, since we're trying to do an NCD investment case, on the program. And then there's also how human resources, another big decision, if you want to take advantage of one of the ways the tool works together and let the human resources requirements come out of what interventions we're putting in, or what targets we want specifically to put in, the number of workers like that, or if we want a general sort of human resource policy, because in certain countries it's more based around adhering to a central or a decentralized human resource policy. But then we click finish making that choice, and then it'll take a few, not minutes, but a bit of time to set it up. Now, the tool is a work in progress. I don't know if I can say that enough. You may run across moments that something doesn't work. A lot of the time you think that you did something wrong, but you're doing something that makes you give an error, and sometimes it isn't you, it's the tool itself. You get a lot of pop-ups when new information has come up. Especially within the LiveSafe tool, they're constantly updating the information. If you're working sort of near the start of one of your projection files or one country, it's good to keep updating and using the most recent information. But if you're using someone else's file or a file that you're comparing to, sometimes doing the updating may cause errors or may not make the comparison that valid anymore. But anyway, you are asked, and you can say yes or no to updating, and you can always choose to always say yes or always say no, or answer the question. So in the exercises, or the exercise of the different steps that I'll do, we'll look at doing after this, when the question comes up, if you want to update it, then the answer you will want to say is no, because if you update the numbers, the results that you get will be different than sort of what the answer sheet will say. Okay, so still not quite. So how many of you raising your hands have actually used the tool before? Okay, so 3 of us have used the tool before ever. So I'll start with a really sort of general introduction on the different modules as soon as it has finished creating the projection. There's two versions sort of officially of the tool. There's one that's the publicly available version, the one that's on the main website. There's also a beta version where the most up-to-date fixes have been taken into account. And if you're going to be using this in a country example, that's probably the one you should be using, and contacting us, we can let you know what the link to use that is. However, the beta changes often, like every day, about there's a new beta release. So something that maybe worked in the beta release yesterday may be unfixed for the beta release tomorrow. So that's one of the disadvantages of working with them. In any case, once the file is set up, you start with this configuration tab. This is also one of the more important ones because it's another set of questions or decisions that you have to make when looking at the tool. You can choose what program areas you're going to include or exclude, what delivery channels you're going to include or exclude. This is, maybe it depends on the kind of country. This is sort of how services are organized in a country. It doesn't have to fit this. There may be more levels that in the specific country you're looking at are considered. There may be 3 levels of hospital care with different assumptions and different prices and different things that you would want to add in here. But this is the basic setup. And again, the more details you put in, the more accurate the results you get out. There's a list of interventions. I mentioned before there are 400 of them, but maybe there's something that is new that you want in your country to add, then this section down here of interventions is where you would do that. You can also deselect ones. There are, for instance, the common example is there are at the very top certain kind of family planning interventions that may not be legal in some countries, and therefore even including them in sort of the framework of results may cause problems. So that's one of those things to just remember, that in certain countries you just have to exclude, say, abortion or family planning interventions. So this will give you the entire list of everything that we have within the tool. Here you can also change a bit of how they're linked with the delivery levels, but that's better to look at someplace else. Oh yeah, one thing is, since we're doing MPVs, there's a separate new program area on the human papillomavirus vaccine. If there's interest, or if there's already that inside a country, or if that's a part of an investment future in NCDs, that's something you can also add in there. This is another thing. If you're only going to look at NCDs, you're not going to make any additions in any other interventions, then it might be worth selecting this option, cost, labor, and visits by disease, as opposed to costing this as a shared resource. So this will give you an estimate, or give you the ability to put in the estimates of inpatient, outpatient visit costs and human resource costs specifically for NCDs. At the same time, we always sort of say that may overestimate the resource costs, because a doctor isn't only going to be working on NCD or treating NCD patients. They have lots of other responsibilities, and if you say that nurse or the doctor you're counting their salary entirely for NCDs, then you're overestimating what it's really costing and what the resources really shared would be accounted for. Another one that's really worth looking into is the drugs and supply list. There's a preset list coming from the global WHO guideline with prices. So there may be different drugs and supplies that are on the official drug list, or the prescribed drug list, the accepted or drug list, with different prices. And in this section, you can change exactly which ones are there. And there's an easier way to do this. If it's common to have this information in a preset Excel file, that comes up here when you put custom drug and supply list. You can either help it create a template for you where you can put this information with the generate header file, or simply load one if you have already set up. It's rather standard, where it has just sort of the name and the price. And if you just want to add one or two, then you can put this add and drug or supply thing. And instead of having the entire list up at the top, you can select sort of which ones are related to which program area or section. So again, if the focus is really going to be on NCDs. You don't need to worry about the others. And you select NCDs, and here you'll see an extensive list of everything that the tool already sort of assumes is linked to the specific different interventions. So there's quite a bit to look at and work through. There are other assumptions within here. So it's not just to think what the price of a drug is now. You may come across information that you expect the price of certain drugs to go down over the future, adding even a bit more of nuance or complexity to your projections. I don't know about specific countries if there's inklings on that, but there may be something that you read that comes out that there's an agreement for a generic version of a kind of drug that you will expect prices to drop by 50% across the world. So you can include that into your projections, and you can make different prices to come into action at specific years. Then there's assumptions on how much you need in terms of buffer stock in the supply chain. A lot of detail you can go into there as well. And how much, this is interesting if you want to add a bit more detail, if you have someone that you can talk to that works in logistics and supply chain in your country, how much, that there's data on how much goes to waste. This could be one of these things where you look at efficiencies and possible assumptions around efficiencies that you can really make to improve how the projection takes into account these things. And then, since the logistics module is also really detailed, you can also add information on the weights and volumes of different drugs, but this is really if you have extra time or want to work on it on your holidays, maybe is something you really want to get into. So there's lots of little details that you can get into and make it even more specific and realistic to your circumstance. Then there's a section that's sort of on the general economy of the country. If you're looking at inflation, the new inflation values come out, or new expected exchange rate values come out, you can add this too, because this can play a really big role too with what the results come out to be. So you can already spend many days just configuring the initial setup of the tool before you even start trying to sort of play around with it. So, assuming we're finished with that, there are 4 tabs, as you see up here, that are really what you're going to be working on and how the tool is really set up. Health services, health systems, and the impact modules, and sort of some add-on tools. Now, because the screen is not wide, it makes it a bit less nice than what you would expect to see on your screens, and which you probably do see, because for instance, for health systems, it's now vertical, but you have these different buttons that you can work with. So starting with health systems, this is what I was talking about, the shared resources that are within the system and that maybe have the ability to think about what additional investments you will have in that country, or you may need to make in that country in relation to make an NCD plan or an NCD investment case feasible. So let's see. For infrastructure, each one of whatever modules you select is going to have what we call a ribbon menu, which is this gray line across the middle of different menus that pop up. For every one of them, it has sort of the same structure. It has first baseline information, then it's going to have possibly some information about what already happens in the country. Some of them have quite detailed reports just underneath this situation analysis. Then it's going to be the part that you're really going to be working on and thinking about what we could do in the future. And then sort of the intermediate results and additional costs. So we'll start with baseline. Here you can update the information that's already in the tool on the types of facilities that exist in your country. So we used the tool last year to come up with a global price tag for reaching the SDGs. And I worked extensively on the facilities and found that the baseline data on the facilities in the tool actually could be improved for over half of the countries that are there. That the data was 5 or 6 years old. In a lot of countries, there's quite a bit of construction and new facilities being added to the system, and this is something you could do here. So as I mentioned before, you can describe a bit better what the reality is like in your country. A hospital, according to the WHO, doesn't necessarily fit to what a hospital in your country is. So a secondary hospital can be quite different. There's going to be a totally different number of beds, different number of specialties, or many things that you can adjust here. And then you can see what the assumed number of facilities. So here, for instance, the tool doesn't have any baseline information on the number of facilities for Russia. So you would want to include this information in there so that you can, once doing applying, try to see if you need to maybe consider investing more, or actually, like in this case, that there's going to be there's lots of slack in the system of infrastructure in the country. Maybe there isn't on the primary care level. Maybe it's really focused on the top, but it really it helps in there. And then there's, again, much more detailed information on what you can add of what it costs to build them. If you have a facility that needs to be updated, what it would cost to rehabilitate it, and what it costs to run. Not to overwhelm you, but there's a lot of different things you can go into much further detail, and maybe this isn't the most interesting or the one that you would spend the most time on. So quickly go over again the kind of things that you can add to add detail in the infrastructure type of level. Do one more, which is human resources. Again, maybe the most important information that you would add would be just the number of facilities and the number of staff or human resources you have. You can't get any estimates of staff that's necessary to implement the plan if you don't put in how many workers you have already in the system, both medical but also administrative. The administrative are a bit less crucial to telling you if a plan is worthwhile or not. The medical ones, I guess, are the most important ones, but you can also put in this information. And usually if you have one, you can expect to have the other. But maybe more importantly is how much you have, you expect to be, how much the salaries are, what the costs of health workers are, and how much they work. There's a huge difference between how many hours a day staff works and how many days a year staff works to the total number of full-time equivalent staff in a country. I remember one country file that was giving a huge, but it was giving a plan that was feasible only because they had by mistake put in that they worked an hour extra a day. And so that reflecting that to be the reality meant that the plan ended up being too ambitious. So for the shared resources for the health system modules, I would really emphasize that at least you look at the baseline value for health workers and for infrastructure. Now, health services is probably the bit that is most important in calculating what the costs of investing in seeds would be. Health services is set up to look at again, the general configuration, skipping ahead to the coverages of the interventions, but more specifically, the specific program level analysis. So if we click on program or channel analysis, we get a new ribbon menu. And there on the left, you get a drop-down menu of the different programs that you can select and go into more detail. And we, of course, want to start looking at non-communicable diseases. So, unfortunately for NCDs, there really isn't any situation analysis set up. This is, I guess, where a lot of donor investment has gone into, say, malaria or HIV, and there's a lot of countries' pre-existing reports that come in. So we would skip into the next tab, which is where you would probably spend a lot of your time for the non-policy specific sides of an investment case. So this, we go back a little bit to how you calculate, how we calculate costs to begin with, and how it maybe is a little bit not intuitive. So it's split into mainly these first three parts, which will simply in the end calculate how many people or how many interventions or times an intervention is going to expect to happen. Current stock is really when you have a kind of intervention that relies on existing medicines and supplies so that you don't have to assume that you don't have anything to begin with, but not that important. The treatment inputs is very important. We'll look at that in detail. Drugs and supplies we already looked at, but you can get to it here as well. If you didn't go at the beginning and configure what the drugs and supplies were in your country, it comes up here because it's sort of intuitively a part that you would want to change at this point. A part of the tool is you can get to the same thing through many different paths. So it isn't such that if there's one thing you really need to change, there's only one way to get there. There are many different we tried to make it intuitive ways to get to the same thing. Here's where you would really go about changing the delivery channels. If maybe an investment case or a new NCD plan wouldn't necessarily be focusing on that example we were talking about before. We're not thinking about having more money, but maybe thinking about ways to restructure the way we deliver services. Here you would be able to say, what would happen if we started doing something like hyperglycemic control at a more primary care level? What would that look like and what kind of effects would that look like? That would happen exactly here under the delivery channels. So let's start by actually looking at the target population. Although maybe here's where I should have loaded the other projection because I think I'm going to get a bunch of zeros here. But maybe if you're just walking through it, you don't need to actually see the numbers. When I want to show you some results, then maybe I'll look at the other one. So because there are so many links between the tool, when you go into changing the target population or the coverage, a lot of the other components activate, and that's what takes a bit of time. But anyway, so these are the different interventions that we have within the tool for NCDs that are more sort of medical or service-based. Target population, as I said before, is the sort of the largest group, the widest web that a specific population would look at. So first one, if you're screening for cardiovascular disease, you would look at all adults age 40 and over. You can also change this bit, but the categories are big because the idea is the target population is big. And then taking it one step more specific, you can click on this tab up here, population in need, which is the same as clicking on the next line from the previous menu. So you can either close this and go to the next line, or you can just click on population in need here. Again, you can get to the same thing two ways, but since these three, population in need, target population, and coverage, are linked together, we put them all on sort of the same window. You can just click through in the tab. So here, it's what percentage of the target population you talked about before would we be targeting, theoretically. So if you're looking at screening for diabetes, you would theoretically want to screen everyone over 40. So that's why here, the target population need is 100. If we put in here that we're only looking at women, sorry, that's even more specific. If we're looking at all women, instead of adults over 40, then the population in need, based on what your country's demographic split is, then maybe here this would change, because then you wouldn't want to have anyone under 40 to be there. But it's sort of already set up so that it fits with sort of general guidelines of what the target population would be. But say, yes, theoretically it would be nice to screen everyone, but that's not actually what's happening. So we have a baseline target, which usually is not something we have within the tool for specific countries. There are some general assumptions, so that there's a general assumption that a kind of income level country is going to have a general level of coverage existing. And then the most important one is what the target is going to be. So when you change this, is where you actually will see the results. This is where you're going to think about what we're going to invest in. So yes, we can say we want to invest in something new, or we want to change the way it's delivered, but most of the time we're talking about a kind of service that right now is only being accessed by a few number of people or in a few places, and we want to scale that up. And this is where that happens. You want to put in what the current level of coverage, what the current percentage of areas or people that are receiving the service, and what you hope to get to. So by changing this is where you're going to see the big jumps in the results, and where it's a bit sometimes very easy and optimistic to put values that are a bit high. There's a sort of reminder tab to the right. There's a separate function called the bottleneck analysis, which looks at the different components, the shared components that you would need to deliver a service, and it gives you a reminder sort of what your limit should be. Without the tool really running and checking it in detail, it gives a sort of a quick estimate of what you really should be using as a target. If you haven't put in much information in these shared resources, these numbers will be quite low. So right now, since it's empty, it looks, the bottleneck number is quite empty. So in the exercise, we'll actually have an example of you going through a case where you have to change the coverage of something in certain years, and then see what happens. So right now it's sort of general, but we'll look at it and what it actually means afterwards. So as I mentioned yesterday, one part of it is the actual services, how many people you're treating now and how many people you're looking to treat later. But there's the second side, which is the program costing, which are the costs that are linked to the entire program that we still need to take into account. And if you missed what I clicked on, and it looks different on here, it's to the right of results. There's, actually maybe it's even on the left on results on your screen, because I think the results should always be left, but it's on the ribbon menu, program costing. Here we have all of these things that a program has to have and that are shared, but that we can't forget about. We have human resources here that are not shared resources. So we're not talking again about putting in medical people that work on NCDs and something else. We're talking about more administrative NCD specific staff. And it's split by level, so you can go into detail as well, or you can put them in sort of summed together. Then we have things like training, also in quite a bit of detail, supervision, monitoring and evaluation. Again, specific to NCD infrastructure that doesn't do other kind of things. This is a bit more difficult to think about, but it's more, rather than the infrastructure itself, it's things within a facility or within a building that's specific to NCDs that you're thinking about adding. Similarly, things that are related to transport. And then maybe here is where we get a bit more related to you in the non-medical kind of interventions we're going to add, media and communication and advocacy investments. So here I'll give an example. Every single one of these program costs can go into a lot of detail. And the way the tool works is that you select the thing you want to go into more detail and double click. We want to maybe add a new mass media campaign. So we'll put that as reduce salt intake. And then we click next. And here it comes out as being quite generic, but again, actually that was a bad choice of an example. Yeah, it's better further down. So so you can put it here, but the NCD specific policy-based interventions, like that would have been, fits in quite better within the last section with section 10. And here we have already set up ones for tobacco, for alcohol control, for diet, for sodium, obesity, and then you can add some other ones. So the one I liked to do was protect people from tobacco smoke. Again, sometimes you'll end up with this and you don't know what to do here. Most of the time, if you double click again, is where you get the more detail. So you double click on the thing furthest to the left, and then we add here a new type of thing. So here would be no smoking in bus stops. And then we have this policy added there. Double click on that policy, and here we get all the things that may contribute to costs of implementing that policy. So maybe there's specific people that we hire to help come across to do this policy, that we have to hire specific consultants, that we have to have workshops, that we need to train people, that specifically there are incentives that people need to receive, both within the program or without, media courses, all of these things. And once again, you double click on any one of these, and you get more details. So you can put in the sort of a general expected cost for what usually we think of as what the budget will be for something like this. What the budget will be for media in 2018. But you can already go even further detail as to what that actually means. So that if you have a budget for media that's going to be 20,000 for a year, you can already say, well, does that really make sense if we want to have 15,000 go to TV time? But then we forgot about the other things that we may need. So that's one of these, the details or the subsections of the tool are also intended to ask questions of people coming up with these ideas. Maybe you forgot about the other things within a mass media campaign that come up as sort of prompts within the tool. So you've got the exercise, but before we look at the exercise, I want to look quickly at the results and the kind of results we can get, because that'll be one of the things we'll be asked to do. What I went through is, in general, a bit of what the costs are. There's one other one that I'm really not that familiar with, which is the impact module of, let's see, where would it be? There. The NCD impact module is going to have already preset the different risk factor type of policies and interventions. So here you would have gone to impact modules and then selected the NCDs module. And here you can set up specifically what kind of policy towards a specific demographic, so male or female, and even more details. But what I wanted to show you was within risk factors. And if you click on impact based on disease incidence, it's going to give you the sort of disease the medical conditions. But what I want to show you was the actual interventions, which will be this 5th tab, which are the sort of standard interventions that we have within the tool, which is, besides the things that we looked at before, the things that you will probably be changing or that an investment plan will want to consider. And unlike the others, the coverage generally is either 100 or 0. You can normally either have a policy or not have it. You can't have half a policy. But what you can vary is what is called the intensity. So there is some guidelines on what this sort of really corresponds to. I think it's within a document that I have, and maybe James could probably also help with what exactly this means. But you could say, I mean, it's set to 100 most of the times. If you're going to implement a new policy, you would expect things to be 0, and then they would be activated to become 100 at a certain time, and that maybe at a certain year you would also increase the intensity. Yeah. So I'm going to now load another projection to show you a bit of what the results section can look like. Because if we would use the one that we were looking at now, we would sort of see empty results. So again, I'm prompted to say that there are updates. Since this is an exercise, this is a file that has been created before, I want to avoid updating anything because the tool tends to sometimes not like things that were updated on top of previously existing things, especially since the tool is updated so frequently. So it's one of the drawbacks of why it's so flexible, why it's constantly being updated, that you may run across that you try to update a projection file and it'll give you an error. It just means that next time you open up the file and you select for it not to update, it won't ever damage or overwrite the file you have unless you specifically select it to save the file anew. And that's a general concept. I mean, generally when you're using files, if you're making changes, save it as something else. Change the name and then you still have the original file beforehand. You're never going to have an auto save with the tool. So this is a example file from an analysis of Saudi Arabia. We'll look at here. Yes, so I went to the program, and again, NCDs, and then looking at results. When we want to look at an investment case, we want to know what the costs are, right? So the overall cost is going to be how many times we did a certain intervention by how much each one of them costs. So the number of times is going to be coming out of results, number of services, total number of services by service package. It's gonna take a bit of time, but it'll then give us a menu, a little window to show how the tool wants to present those results to us. If we're trying to have it visually for a presentation, there's gonna be an option to have it be a graph. If we want to come up with the number, then we're going to select the table. When we look at the many different result menus, there's always going to be a choice how you want, or how the tool's going to ask you how you want to show the resulting data. And there's going to be, you can show it, you can select which years to show, you can select if you want to show it every single year, if you want to show every 5 years, if you want different kinds of graphs, line graphs, bar graphs, and so on. The result is something that activates all these different modules, so it's one of the things that takes the longest time to process. Almost there. Okay, so this is going to have the years through 2030. What we really maybe want to focus on is through just 2020. We don't want to see the results by the different levels, but by program area because we're focusing on NCDs, and we want the table. So in this, although the idea was there's going to be a bit more of an not so empty, there's some information that has been put in on treatment of myocardial infarction within CVDs. With diabetes, there's glycemic control, trans fats. So you would, assuming that you're not doing an extensive list of new investments and new interventions, you would select, and I think there's a lot of detail on respiratory disease, you could, since this is really made to be linked with Excel. You would select the rows of the interventions you want and copy them into an Excel table. That'll give you the quantities. So that's one part of the things that are going to give the costs. The other one is, of course, how much things cost. So we talked about how things are made up based off of what the supplies are. So yeah, so it would be within treatment inputs. And again, you would have, here it's split by different levels. You would again copy what this average costs for the specific interventions you're looking at would be. So if we're looking at the other one is respiratory disease, it would be copying these. You would multiply that by the number you got before, and that would give you all of the supply costs. But supply costs, as we saw, aren't, or medicine costs aren't the only thing that we need to take into account. We also need the program costs. Those over here. Oh, yes. So for program costs, that is under results, prevention summary. So that's a less than intuitive step. Okay, on the table. So I didn't have any things put in here, but here's where the program costs that we would have put in, like the new no smoking in bus stops type of costs would show up. So you would add those together with the ones before, multiplied by the number of services, and that would, in its easiest way, give you the resulting costs. There's another way that would give you everything together, but usually when we're doing an investment case, we want to know what the costs for each one of our interventions is. Then we want, of course, to know what the resulting impacts are. So we would again go to the impact module, the NCD. Select which one we wanted to see the results from. And since this projection had a lot of information on respiratory diseases, in results, under that one again, health impacts, and then whatever one we want to look at. Usually we want to look at all of these, healthy life years, incidents, and that's the different impacts that you would get out of it. Those you would link then to the corresponding tool outside that would tell you how much improving a healthy life corresponds to in an economic side of analysis. So here again, we do a table. And since, again, in this case, I didn't go through and make any changes, you'd get the resulting healthy lives over time. Now, we've heard that sometimes the tool gives some strange results here. You want to, again, this is likely, since it's the newest thing that we've had it on here, maybe you think that you're doing something wrong. It's worth going back and checking things, but it's also good to, as I said before, use the help functions, write to us, write to the developers, and say, I'm getting this strange result. Why is there a 0? I've put in this policies, what's going on? And since still there aren't that many people in the world using the OneHealth tool, they'll get back to you quickly. The times I've talked to people, it should be that the developers on Avenir will get back to you in a couple of days. If they don't, you can even write directly to us and we'll poke them and say, these people are using it. Can you let them know what's going on with them? Yeah, these are the specific results related to the NCD risk factors. Of course, if we wanted to look at what the results sort of overall within the tool would be, that would again be results here, and the number of people that were coming up there, or if you wanted to check what the requirements on the shared resources would be within the results, there's an entire list under summary outputs. Things like how much of staff is being used, if you have enough beds, these things like that. So this was a bit of a quick walkthrough. Now the step that we do is to look at the exercise. There's two projection files that are needed for that. I don't know if Alexei, you have the ability to share them. If everyone hasn't gotten them, it hasn't linked to the email. Yeah, but there were two files, two projection files to send the email. No, so we can share those via USB, I guess. Yeah. Okay. To actually do the exercises and so to see we can compare the results and see if we're coming up with the same answers. And I can also open it up here so that if people have a question or have some problems, we can look at it together. So yeah, I would say, I mean, if the lists that the agenda was sent to yesterday is the same that was in the email that I got, I can forward that same file to everyone. Sure. So while we do this, we can also take some questions if there's already some initial reactions. Maybe, Nick, you want to?
Yeah, thank you very much indeed. That's very helpful and clear. I just want to kick off. If any of our colleagues here end up, well, some have already, in countries working on this OneHealth tool, and an economist in the country comes up, or the Ministry of Health or the Ministry of Finance says, what are the criticisms of this tool? What do the critics say? It would be helpful, perhaps, for them to know what the naysayers would say about this. Could you just outline?
Sure. So if someone has used the tool a bit, or has a bit more of a detailed, they'll say, you need so much time and so much data and so much resources, is it really worth it? That's the one that comes up a lot, and my experience, Latin America in particular, has been that besides one country, no one has wanted to do it because it requires so much data. At the same time, as you saw on the map, African countries are the leaders in using it. And if they can manage to get resources and people to work on it and get it to work and get some positive results, then I'm sure that everyone else in the world can too. Since the data has a lot of preset default stuff already in it, if you're only focusing on certain small things, then it isn't that much more that you need to change. But the more you change and the more you update, the better the tool will give you in terms of results. So the idea is, yes, it's time consuming. Yes, it might be expensive to have to bring someone out or have an expert to be trained in it. But it's probably the tool that allows the cost and impact calculations to be probably the most comprehensively done, most comparatively done, and I guess you could say fixed to a standard that if you do it now and in 5 years, it's still going to be valid and still going to be comparable. So there are many Excel-based tools or people that can come up with their own tools can do today, but that gives you really an issue of comparability. And the other thing, since I'm mainly a user of this tool at the system-wide level, what we talk about or we like to talk about is even if you're using it in a program-specific level, the tool is going to not usually overestimate. It's going to say, these are the things that are specific to your program, but these are the things that are shared, the costs that are shared. So if we're talking about the case, so someone wants to do an investment case in a country on NCDs, but then there's another one that also wants it to be done on malaria or HIV. If both of them are done in the OneHealth tool, then you can put them together and you can sort of say, well, most of the deaths that you're saying are being averted thanks to HIV would also fall under deaths averted under NCDs, because in the end, what we really need is more doctors. Another common aspect of the tool is, or criticism of the tool is the fact that we only focus on the health sector. And on one extent, yes, the health sector is what we sort of know, and the health sector is what we have a ability to sort of confidently say we know how to cost this, we know how to make the estimates that reflect what we need in the health sector. And a lot of the times there are needs outside the health sector, but we don't want this to be not the OneHealth tool, but the one tool that costs everything. That would be maybe even a bit too ambitious. But there are things being added to it that are not exactly health sector, but we always try to separate the things that are above or below the line. Costs that the health sector are supposed to be attributed to. So like there's going to be a section on clean cooking, cook stoves that affect the environment. The policies that are really supposed to be paid for or covered by the health sector are there too, are there, and the ones that are outside are there too, but the costs that sort of they're separated out to say these are health sector ones and these are not. So where we feel like there's a real mandate for us to include non-sector costs, we will continue to do this. As I mentioned, in the list of the ones that we want to add, there's one on health security that I'm directly involved in. There's a lot of things that are specifically agriculture section or agriculture related or sector related that aren't health that make up a part of health security. And the module that will be within the tool is foreseen as being really focused on the ones that are covered by the health sector, but hopefully also have some of these non-health sector ones too, but always presented split separately. I don't know if you have even a further
Okay. So that's very helpful. So again, if I was then a Minister of Health, I might then say, okay, so you've entered all these different data points. How do I know that what you have entered is realistic? Who have you been getting this information from? Have you got it, because you haven't come to me and asked me about these various campaigns, so which officials have you been dealing with? And how do I know they're not being inappropriately ambitious or inappropriately reticent? So how do you respond to that?
So I would say if you only have one scenario, that's probably a very fair criticism. And I always like to suggest make many scenarios. Even if you aren't actually getting the opinions of many people, it gives you the idea that you only haven't asked one person and that you have sort of a general range of possibilities to present and to choose from or to reflect the reality of. More time means that you can ask more people and get more inputs and make these different scenarios more specific to the different expectations or ambitions of that.
So again, I'm not an economist, and I apologize for my ignorance.
Sorry.
But when it comes to statistics and in epidemiology, you have confidence intervals that people all understand and feel confident in. You have the same here, do you? What's the approach that you use, which is the equivalent of confidence intervals?
Sure. So it would mean coming up with a few alternative projections. Taking the assumptions that you've added into or put into the tool and tweaking them a bit. There isn't a standard sort of confidence interval plus minus 5 degrees. It means a bit more manual work. So if you're getting a result because the coverage is at 80, what happens if you put it at 85 or 75? Is in theory like 2 more scenarios that you could do. And the tool allows you to present the results of the scenarios at the same time. That's a bit more of a further step that we didn't get to today and it wasn't in the exercise, but that you can take projections and sort of merge them together and present the results together. So that you're not giving a false impression of being certain of what things will happen when you present results. Jeremy?
You know, I'm not sure to what extent, I mean, you know, the OneHealth Tool, there's an element of working with it, and you've talked, I mean, I really like the presentation that you've just done, and you did not talk too fast, by the way.
Thanks.
But there's an element of working with the tool that is, you know, you press a button and you get these results, and it's a black box. Can you just give us a little bit of a peek behind the curtain there, and talking about, you know, the way the different costing modules and if impact modules are working, you know, the demographic backbone engine, projections, the different disease aspects, the costing, I mean, maybe just a quick peek I'm not sure, I mean, I'm asking you this, so you probably don't have slides on it, but
Yeah. Yeah, so that would be, I think there's maybe a separate like hour-long presentation on that for those that are interested. But yes, the point is that there are ways, and this comes up in the e-learning course that hopefully you'll do, how the different modules are linked to each other. So, for instance, if you're changing so demographics, there's a demographic projection module that runs in the background of things, so that when you change an intervention that affects, as I was talking about yesterday, the number of expected births in the next year, the demographic projection module picks that up, transfers that to then when you're looking at interventions that are focused on births or on after a year in the projection the next year, then the module that works on immunizations. And so then if you're going to have more children surviving as well, if you have more children surviving birth, then that is picked up by this module too, and that's then carried to where you're looking at the costs of immunizations. So maybe you keep you're looking at, again, this isn't maybe the relevant case for you, but it's really easy to see within births and children. If you're looking at immunizations and you don't change anything, and you have something that makes more children survive childbirth, that link through the survival through the demographic module then links back to the immunizations, that then in the result suddenly shows that you have a bunch more costs going to immunizations that you didn't expect, but only comes from the fact that more children are surviving. And that so it takes these many steps, and then maybe if they're surviving through immunizations, then there'll maybe be more people who are getting infected with AIDS, and then the AIDS module will pick this value up and report this result back into the total summary of the results file. That's probably the nicest picture in my mind of how the different steps and how the different things are linked together. Sometimes there are ways that you can put in information that's not exactly conflicting in two different places. And the tool, when it's really conflicting, will give you an error message and say, you've already changed this somewhere else. If you're changing for instance, an assumption among human resources in one of the disease-specific programs, it says you can't say now that people are working 8 hours or that nurses are working 8 hours a day on your specific area if in the other side you said they work 10 hours a day. Sometimes there are going to just be highlights saying, be aware that you have put this or that this assumption exists somewhere else. So there's that connection between the tool and the modules going on in the background too. Between the assumptions, especially the things that are shared, resources that are shared, and the ones that you're sort of putting in as being program specific. Yeah. Anything else?
Any other questions or comments? Probably the right thing now is to
do the
exercise, because that will then flag up any questions.
Yeah.
And I think we will just come back to this again later in the day, where we come to some of the practical issues in countries, when it will be great to have James and Anna talking about what's actually happened in the country and what it was like. Okay.
So we're just trying to get through the projection files. So
it's used to. Everyone needs to go. Oh, you have to save the notes. Save them and save them.
So he's going to send an email to everyone around, but we can maybe also speed it up by if we had a few USBs and people feel comfortable putting four USB.
And is your recommendation that people work individually or in groups of two? What works best?
If we're sort of at a similar level, I don't want there to be working two and then one person knows the tool relatively well and the other person's never seen it. Then it would be best to work for yourself. But generally, if you pair up with someone that sitting next to you that you feel comfortable with, that has equally never seen the tool before.
It sounds like nobody's eaten except for Anna and James, is that right?
Yes, but
Oh yeah, of course, sorry, apologies, yes.
I think individual work can be very
Individual.
go one point by one by themselves.
Okay, individual.
So maybe I would say it's the exercise is split into 4 parts. Maybe after you finish part 1, you can see if your neighbor is sort of has finished recently, and then you can go over. Part 1 is really quick and easy. Part 2 is a little bit more. Part 3 is perhaps the most difficult, and part 4 is just sort of think about what you have. I think that everyone should have the files now. While I'm setting up again, and it's also worth noting or saying that there are circumstances or times that we do a OneHealth Tool intensive training workshop, up to 5 full days of training on the tool. Part of that training includes changing interventions. So if there's an intervention, I mean, especially these that have to do with NCD policies can be a bit difficult to understand or that are a bit strangely worded. You can go into the tool and change what an intervention means, but you just have to make sure that the effect size that you're relating to an intervention is backed up by something, and that the inputs that you're putting in, the assumptions on how many things that you need to deliver an intervention are accurate. But if you change the effect size and you change the inputs, you can change something that you can't get data on to something that maybe you can get data on. On the backstopping on the side where you do the peer review, then there'll be something that pops up to the person reviewing that the interventions aren't completely the same. But if that is what you need to do in order to get a result that makes sense, then it's definitely something that you should and could do. So can I take one of these? So let's look at the exercise together. First thing to notice, if you had walked through the tool with me already and created a projection for Russia, you're not going to be able to do the first step. Because one of the things the tool can't do, even if it opens many projections at the same time, are open projections if the years are not the same. So in this exercise, we're going to start with a projection that starts in 2015, and any new one can't start in the past, so that'll give you an instant error. So what you need to do is in the projection, in the OneHealth Tool, you go to File and Close Projection. So the one that you were already working on. I'll ask if you want to save. Maybe you want to save, maybe you don't, but. So, we want to start with September 2017. And since this is supposed to be an exercise, I'm not going to do the exercise up here with you, but just to make sure that we get started, this pops up. You're going to want to click to continue. This just shows that the files are made with an earlier version. If you don't click to continue, you're not going to get the file loaded. But then you're likely to come up with a question where it says, do you want things to be updated? And then you're going to want to select no.
Где есть нажал? Он говорит, что не надо. У меня все равно ничего не открывается. Хоть конем. Нет, кстати.
So, in terms of going through things, I can either say that in 45 minutes we all stop and I go through them one by one, or that in 10 minutes we go through step 1 and then 15 minutes later we go through part 2, so that we're sort of keeping track. The second one's better maybe? Okay. So in 10 minutes, I'll walk through part 1 with you, the part that's actually not just looking at clicking on things, but the one that asks questions. So you should be Right. So if you get an error, raise your hand and I'll come by it. Okay. So you may have noticed this first one is really introductory. Just looking at the different tabs, clicking on different things. Sort of the same that I had gone through. Look that there's what comes up when you click on summary outputs, all the different kind of results that come out. When you were looking in a program area, kind of things that show up underneath, configuring the input. But then the question was, if you have a specific intervention, what are the treatment inputs? So, sorry, I went a bit quickly. Picked one where it was treatment of cases with heart disease as an example. Clicking on the cost there gives you the different things that form up that. Gives you all the drugs for you to see, gives you all the medicines, the personnel, and the outpatient days. These are the things that are really the inputs, the P's that you need to think about. Again, this is just having an idea. But what the first result was, or the first thing you had to look at was, what are the costs that we're looking at in this projected example? What is the breakdown? So within results, in summary outputs, we have summary costs. The tool is gonna work its different modules together, and it's going to give us a window to select how we want to see the different results. And I hope that you selected then the pie graph that gave you then a breakdown of the costs. Now you can't, it's a bit difficult to look at many different pie graphs for each year, so you look at one at a time, year by year.
Только я не помню, что он это выделили здесь.
So here you get, if you want a table, we wanted a pie chart. If you wanted 1 year or many years, we wanted 1 year. And this is what we get. So here we see that in the first year, it's really medicines that's driving the cost. Now, the screen, I can't actually click to move next here. Yeah. Oh. So you would be able to, in yours, since it's now a limited screen, you would be able to click forward. So, but it's sort of easy to tell. This is a pie graph, and most of our costs going into this plan are in the first year medicines. The other one you're supposed to find is the overall metrics. Again, single year, since it's all metrics, it's going to be a table. And then it's asked, what are the costs per capita? Now, the table that comes up is going to give the results in many different ways, but the bottom one, which decision makers, finance tend to like, is cost per capita. And here we can see when there's already information that we put in on scaling up a series of interventions, that the costs per capita are going to go up quite substantially from 2016 to 2030. You can see that when this down here is changing, something's happening and your tool isn't frozen. Sometimes it can seem like it's frozen, but if anything happens down here, then you're fine. You just have to wait. And it's a bit strange when red means it's almost done and green means it's only starting to work. But almost there. So it gives us totals split by capital versus recurrent costs. And therefore, this row right here is what we were looking at in the question. At the beginning, it's less than $31 per capita. And by the end, in 2030, we're up to 56. So this is a plan that has a bunch, you would seem to think that it's an ambitious plan, but the overall metrics also shows that the population has gone up to 65 million in this country from 50 million. So it could just be that by demographic changes, the costs will be going up. The next step, part 2, is going to ask you to look at actually making some changes and see what happens. And so the first step is really just looking at what this plan means in terms of human resources. So we'll guide you towards what the first thing you would do is, again, results, summary outputs, and the one you're going to look at is staff capacity by channel program area. So in 10 minutes, we'll come back to where the pictures finish in the exercise, which is 1, 2, 3, 4, 5 pages, and look through this again. This is a slightly more tricky because it actually is an example of what you're going to be doing in terms of changing coverages. So again, if you run into any errors, if you run into questions, you can raise your hand and I can come by. I'm quite through it, but hopefully you'll be able to follow as I run through the second part of the exercise. So question here is, we have a plan that we're scaling up NCDs. And before we do so, we're just going to look at, out of curiosity, how things are already. So we want to see what kind of workforce availability scenario we have. So again, we go through the select health services, results, summary outputs, and then down here, staff capacity utilization by channel or program area. And we're going to want the bar graph. And among staff type, we're going to pick nurses. And we're going to get this. Now, we have a lot of years in this plan. Maybe it doesn't make much sense to have 2016 now at this point. But there are many different types of workers we could have picked. Picked nurses because there's a decent supply. There's an indication of at least some slack of supply of nurses in this country in this plan going forward. The gray bar to the right shows that there's a plan to increase nurses now from around 11,000 to nearly 14,000 by the end of the plan, and that the projected number of staff you need, all the bars on the left summed together, seem to be below the amount of nurses you're expected to have. So that's a positive thing to have when you're thinking about scaling up, increasing services. So now we're actually going to make that change. So we want to go to either through program analysis and NCDs and then down to intervention coverages, or simply in the intervention coverages big button, since that's one of the things that we use and everyone uses the tool uses the most. The only thing is that if you click the big intervention coverages button, you're going to get every single intervention that the tool has, and then you have to find the ones you're after. So we'll do that just to give you an idea. Starting out with maternal and child health, you have to scroll almost all the way down to NCDs. Yeah. So in this country, there's a plan to scale up mainly management of diabetes and cardiovascular disease. And so we have these interventions here that show up as being treatment for diabetes. But we are going to say that we're focusing on the first ones that you can see nicely enough on one window. And then we're going to say we have done a lot of difficult work and figured out that in this nice coincidence that 10% of the populations in need have coverage at the moment. Actually, since this works like Excel, we could just copy and paste. So I just clicked Control C and then Control B. And we want to, by 2030, get to 45. So you notice that we have a bunch of zeros in the middle. There are several ways that you can go about thinking about how you're going to scale up. We did a lot of this thinking in this exercise for scaling up towards the SDGs. There could be many different opinions on what to do. The tool has a few automatically suggested or built-in ways to scale up. You right-click after selecting the years horizontally that you want to scale up between. As long as you have the baseline year as the leftmost and the target year on the rightmost, you then can go down to here where it says interpolate, and it gives you 4 choices of how you want to connect the baseline to the coverage target. If you want it to be front-loaded, so if you want to scale really quickly at the beginning, if it's something that's quite easy to do, there's a lot of space or slack in the shared resource to do so. If you want it to be exponential, so that it's really more near the end, more S-shaped, or more linear. So we're going to click on linear, and these zeros changed to values so that it linearly connects 10 to 45. Then I'm going to copy, Control C, this, and then paste them down on each one. Then the same is going to be for glycemic control. And quite importantly, we have to make sure to click on this button down here, transfer coverages to impact modules. That gives you a reminder that you have to make sure that they're correct. If you, for instance, put a coverage level over 100, you're going to cause all sorts of errors with the tool. It just reminds you to make sure that the coverage levels are correct because of how everything is linked together. But you want to make sure that you remember to click this button, because otherwise you won't see any result from changing the coverages. You will have put the data in, but if you don't click this button, it'll still think that it's as if you hadn't changed anything. Now we get this message that it went, and then you can click close it. There's a suggestion to save because you have made a change to the coverage, and if you have the sort of an empty baseline projection and you start making changes, it's good to always have that empty one to revert back to in case you do something that causes a mistake or causes some errors. So now that we have made this scale up of these service interventions, we want to see what we looked at before in the number of health workers and see if that made an impact on the number of health workers that we need. So again, under summary outputs, under results, you go again, staff capacity utilization.
Если изменения, теперь надо результаты. Ну, тут работать.
And then we'll do the same as the one before, just looking at the per capitas. Maybe I don't need to show that to you up here. But again, we have the bars like before, over all the years, single year. And this time, I didn't select nurses, so I made a mistake. So this looks different than before, and you might have this happen to you and say, something's changed, but it doesn't make sense. It was only because I forgot to select the nurses when I was getting to the table.
Вон ошибку.
I put all. So go back to nurses.
Почему он говорил, что они что-то дополнительно сделать, что
This time
Мы сейчас должны...
we see a tiny bit of change,
Вот ты
but
делал, да?
so that the bars on the left are, especially the NCD bar, this sort of olive green one, has gotten bigger. But by the end, it looks like we're still a little bit under on the left side. So this gives us the idea that at least within this change and these targets that we've set, we're not going to a level that's too ambitious. If we want to see it a bit better, in the same thing, instead of setting for all years, I'll just look at the last 3 years. And here we can see, since it's only looking at the last 3 years, did I do the wrong thing again?
Что-то я сам...
Yeah, I again picked all. Just looking at the last 3 years.
Я понял, там разбираюсь. Извините.
I have to start over again. So the program crashed.
Что не работает?
Happens every now and then. A way to avoid it crashing is if you have many graphs that are graphs and charts that are up on the screen at the same time, you're going to get a higher likelihood for it to
Да,
crash.
сейчас включай. Так, ну слушайте,
That should happen. So I noticed I was doing this exercise before, and I have sent a message to our developers saying, "This is a crash. What's going on? Can you look at it?" And I hope they'll take a look at it.
Does that, do you get a prompt to like notify the developers when they read?
Sometimes you do when it's an error, I guess, that is within the thing, within the program, but this was one that it was too much for the computer itself to handle rather than a problem with the software that caused the crash, I think. In any case, did anyone get to the doing with the financial space module, the last part of the question? And can tell me if the expenditures go beyond the physical space?
нет, мы не готовы.
Or I'll do it. No, now I have to go through and change the coverages again since it did that. So yeah, maybe to
А в каких полях он сказал?
so I can do it really quick.
Углеки.
So the different things that you create will show up as small tabs. There's a welcome tab right now there. All the different graphs will start showing up one next to each other along here.
Вот он сказал, углеки.
If you get to the end, then it'll be tricky for it to keep working because it can't handle. Usually computers, at least we work with, can't handle that many more graphs or charts or tables going up. So instead of waiting for this to be set up and go through again, you have another 10 minutes for the next part, task 3. And this one is a little less of a walkthrough than the previous one, so there aren't pictures of the things you're supposed to click on, and a bit more questions. And the very first step that you have to do may likely give you an error because it's a new projection file. And if you just open that projection file, you're going to get an error. So you have to...
Слушайте, я неправильно понял. Оказывается, я понял.
Since the new projection file is going to be different, focusing on different years than the one that you already have open, there's going to be an error. So you have to make sure to remember to close the current projection file before you go on to the next one.
Ну послушай, что вы делаете, что он не с вами открывается комиссия. Результаты не получили.
Okay, maybe to look at before you forget if you haven't opened up the next projection file. So we changed the coverage levels. We looked at the staff capacity. It was still below what we expect to have for nurses. Then we looked at that the costs would still go up. They will have gone up from 56 to over 60. And the last one was to see if we have a budget for this. So in here we would have gone under health systems, and then the last one on the right, financial space, and then results, and then expenditures versus fiscal space. And so we see that red is the budget we have, blue is the scenario we have, and that after only a few years we really start scaling up things. The expected costs are already above what we have as a projected budget. So that while we are maybe not limited by the shared resources of health workers in the system, we're likely going to be limited by the budget that we're going to have. So the next step is if you are, so it's unlikely that you will be faced with a projection that looks like this, but it's also possible to limit what other people can do. So if maybe you are going to get help from others that are working on the tool and you don't want them to start changing the assumptions of everything else, you can actually lock what modules they can use. So as I said before, to open the other one, you have to make sure to go to File and Close Projection, the one you're working on, and then open the second one. So it's task 3 exercise. Once update it.
И на говорить. Не, надо попробовать какой сделать файл. И какого лучше последний. Наверное, overload. Это он сохранил.
So here we go. You can see things are gray. Within health systems, everything is gray. And that's a good thing, because if we're splitting the work among many different people and you want someone to only make changes in the NCD module and not start saying how many health workers they have, then it's great, and maybe that's a good thing. And it's also not so difficult to do. In the e-learning course and in any intensive training course, you would learn how to do that. Here, we go back to health services and look at the program analysis. And here, all of the others are going to be gray, except for mental, neurological, and substance abuse disorders. So, as I was saying, it's 11:17, 11:18. At 11:25, I'll pick up again and run through the next answers, or the questions, and hopefully then we'll be done after 5 minutes or so.
I think you're still on Geneva time.
Yeah, so this is 11:18, it's 12:18, yeah.
Is your flight leaving at Geneva time or Moscow time? Or any other time?
I was taking a train, that would be an interesting question. Because everything is on Moscow time by trains. I was once on a train that was going to cross the border into Mongolia, and I couldn't figure out if the train was supposed to leave at Moscow time or Balkan time. So it was like 10 p.m., so I wasn't sure if it was supposed to be there at 2 a.m. or 10 p.m. Or even like 3 a.m. And the answer was 3 a.m.
Wow.
And it was extra tricky because I had a visa until the specific day. And it counted what the time was in Moscow for the
So
visa.
it mattered the night time you're leaving or morning.
So yeah, because it would have been past midnight, it was the 28th as opposed to the 27th, my visa was still the 27th. And it still technically was the 27th.
Even though it was the next day.
Yeah. So, we know that it's only this within health services, within program analysis, that only mental, neurological, and substance use disorders is activated. We click on NCDs and everything is gray. Click on this one and it's not. So then we go under intervention costing and intervention coverages. And the exercise here is that someone has already, that is a specialist in this area, has made an Excel file with the different services and the different coverage levels, and all of these are in the tool except for one, which is management of epilepsy. So the target, yes.
For this case, the situation analysis, it could be included if we buy the health services of the previous model, health services for the whole situation. If you want to,
If you want to look at,
if you want to get the situation analysis
yeah,
for this mental, for example, neurology, the
Yeah.
situation analysis, we should complete all the data what we miss in the health services and
so in this case,
yeah.
This is, I guess, not that realistic scenario, but all the other things in the rest of the system are grayed out. You can't change them in this case. In a case where it wasn't done, yes, you would do this summary analysis that would give you exactly a wide picture of the circumstance at the moment.
Yes.
Yeah. So we went into the coverage levels, and then we go down to find management of epilepsy. Is that it?
Я так тут написано, что людей, а я
Yeah,
так
yeah.
понимаю, не людей, а этих проведенных
I believe this is correct.
судов.
There's another one.
Какой смысл, если не понять, каких судов?
So it's 40 across the board, so we wanted it to go up to 60. And then, like with the previous exercise, we're going to select them all so that it's interpolating linear. And then transferring the coverages. So then it asks, what are the, what are the number of people that are reached now? Total number of services.
Ну, что-то не задумался. Типа да, показывает.
Almost done.
Он показывает, я думаю.
So here we get this. And so the number of people being serviced, we see drastically goes up, particularly in, well, both in clinic and hospital level services. The other question was, what about the costs? Especially the drug and supply costs, that's just the second one under results.
Да, он типа только в этих, только в больницах он жил. А у нас получается совместно.
So if you didn't see it, I clicked on results and it was just the second choice under the drop-down menu.
Это другой вопрос. Там у меня, кстати, получается 15. Ты за какой год смотришь? Не знаю, что.
And here, again, drugs and supplies, although it could just be drugs, could just be supplies. Again, we're going to select bar.
Показываем, как он получается.
And here we see, even if we saw from before that we had many more services happening at the clinic level than the hospital level, now we look at the drug and supply costs, they're almost the same. Clinic and hospital. So we already sort of intuitively see that this service being done at the, or these services being done at the clinic level is a much more efficient way to do it. The next one would have been to look at the results in terms of health worker time, but we'll skip onto the last question, which is on the back of page 12, which is saying, what if you wanted to be more ambitious? So what if you were then to change the interventions that are under anxiety or depression? Here the idea is there are some that are mild and some that are moderate or severe. So you have to go into, again, the coverage list of the different interventions, different services, and move the targets up to 75. So here we have the first one that's mild. So here we put 75. And circulate. And then here, this is severe, so that's 40. And the next one is 40 as well. So we're really increasing what the ambition under anxiety disorders is here. It's also the question is to do it also for depression, but do we skip at a time? I'll skip that. And then quick transfer coverages to the impact modules.
Sometimes we cannot have, for example.
So this just changing 3 different interventions to have a higher target. If we then look again at the results we looked at before, number of services, and then after that we'll look at the costs.
It's a good first step. In this case, it's the first step. We say, here's where you start.
It is better to use exception. If you work one by intervention,
This is a question. Like, let's say you do.
So now it's taking a bit more time because we made the change, so all the different modules have to run and update themselves again to take things into account.
And if you
Here it's ready.
smoke-free environment, that may be excellent. If you do them together, it's not going to be excellent.
Here we see that
It'll be
this time the clinic
smaller percentage.
services are a
Some of the people
lot
have already
higher than what they were
this
before.
one. So these.
And then it's also worth looking at what that means in terms of costs.
And then they're trying to figure out for Georgia because we've got a whole package.
So again, we clicked on results and then drug and supply costs.
One together, it's just the total. It's going to be a small.
This is good.
Thing, bar chart, everything is fine as it was. And both seen increases. So we didn't look at what the results for health workers were before. Again, under the same thing, under results, under resource requirements,
Possible.
Yes,
What can we get
it's
to?
possible to replicate.
There
Then
is-
we can expand.
correct? Yes. Yeah. And this will give you the number of health workers you need. So for the investment case, as I mentioned before, a next step would have been to sum up and take out all of the number of services that you end up doing. This is the number of workers, and you see the required number of workers drastically goes up. You're thinking in terms of number of minutes from requiring 2.3 to over 7.3, going 4 times as many personnel minutes for nurses from 11 to 41. So just by changing a few interventions and making them really ambitious, then you're putting a really big demand on the system. So as I was saying, for an investment case, what we really would have then gone to do was to look at the number of services and then copy those out into Excel, look at the cost of each one of those services, copy them out into Excel, and then look at in an open projection what the impacts would be within the impact modules. Now, this is really just an introductory skimming the surface use of the tool. On one side, you may feel that it's something that is scary and really big and really complex, and hopefully that wasn't the reaction you have. And instead, it should have given you an idea of how much you can possibly do with the tool. If you then later choose to play with it in your own time and look at the different things that it has, especially where there is some already existing country data, you can sort of see what you can already get results even without having to put new numbers in it. We do intense training courses on the tool, usually a full week of training to be at a level where we sort of really feel that you have mastered the tool. But as I mentioned, by this year, we really need to have it done by this year. We'll have an e-learning based course that will be over 5 modules that doesn't really replace an sort of a full intense week-long on hands-on training, but does a pretty good job at covering most things, and that therefore a second training or a more intense training or working with someone that uses it well, sort of training on while you're doing it, would only supplement it. Will only help to do really advanced things. Like as I mentioned, if you want to change the example of one of these interventions, if one of the SALT interventions focuses on a particular demographic group that it's really difficult to get data, figuring out how to change that to the data you have is something that you would be, a more intense hands-on training would have you do. We could probably have a lot more questions and would like to have a lot more time and a lot more exercises going through this tool. But this is what we have thought for you today as a sort of a taster, as an introduction in it. And I would recommend to keep your eyes out, and maybe through our colleagues, we'll let you know when the e-learning course comes out, so that as soon as that comes out, you're ready to take a look at it and try it out. And we haven't tested it, we haven't piloted it yet, so before it's officially launched, if you want to run the e-learning course, you can get in touch with me or with Karin, so that you can be maybe among the people that piloted that too, and in a way also improve your knowledge of the tool without having to attend one of these in-person trainings.